So much, Doctor.
نغطي هذه النقط.
Thank you so much. We thank you for attending today. I would like to start. Today we're going to talk about the epidemiological intervention, and lastly, the nutrition requirements and support. The colorectal cancer is one of the most common malignant neoplasms in the world and the 7th most commonly recorded tumor in Egypt. That's according to the National Cancer Institute registry at Cairo University. Colorectal cancer is the 3rd leading cause of cancer-related mortality in the world. The risk of colorectal cancer increases approximately linearly with increasing with the body mass index between 23 to 30 kilograms per meter squared. So this means that the main risk factor is obesity. Patients with a BMI more than 30 kilograms per have a 50 to 100% increased risk compared with those with a BMI less than 23 kilograms per meter squared. This relation is stronger in men than in women. The International Agency for Research on Cancer has classified that red meat as a group 2A, and this means substances probably carcinogenic to humans. The modifiable risk factors include the excessive consumption of red meat and processed food, high intake of saturated fat and trans fat, excessive alcohol intake, and the food additives and preservatives. The American Institute for Cancer Research recommendations for cancer prevention. First of all, that we have to keep a healthy weight. Second, we have to be physically active. We have to limit the consumption of the sugar-sweetened drinks and to drink mostly or more of water, of course. To limit the consumption of the red and processed meat, as we said previously, and to eat a rich or diet rich in whole grains, vegetables, fruits, beans. Also, we have to limit the consumption of fast food, other processed foods high in fat or starch or sugars. Limit the alcohol consumption, as previously said. And of course, after that diagnosis, we have to follow these recommendations if we can. Cancer itself is known to negatively affect the nutrition status of the patients. So it's worth underlining that cancer treatment also causes side effects that affect the nutrition status. Therefore, it's necessary to follow special nutrition rules in patients with colorectal cancer, since 30 to 60% of them. So the effects of the tumor and its treatment, it causes the inflammation, fatigue, and low physical activity, and reduced energy intake. There is a malnutrition, of course, associated with the colorectal cancer, and the tumor itself releases inflammatory and other factors that affect the brain, muscle, liver, and the fat function. Accordingly, on the brain, it causes altered appetite signals from the CNS, causing anorexia, and so reduced caloric intake. And on the muscles, an anabolic-catabolic imbalance, causing muscle wasting and reducing the muscle mass and strength, and causing fatigue. On the liver, there is an acute phase protein production, and so repressing the drug clearance and raising the risk of cancer treatment toxicity. On fat, cytokines stimulate increased lipolysis and cause defective lipogenesis, which is maladaptive and wasteful response to the low food intake. Here we're going to talk about cachexia mainly. Medical nutrition care depends on a patient's nutritional and metabolic needs, which are related to cancer stage and nutritional status. So worsening cachexia with intensifying inflammation requires adjustments in nutritional care, and so better to refer to a nutritional specialist in the early stages, so that we don't reach the refractory cachexia where the lifespan is, or the life expectancy is less than 3 months. The goal of nutrition in colorectal cancer patients is to optimize the effect of medical and surgical treatments, to enhance the recovery, and to promote the healing, and to boost the immunity and prevent infections as a whole. Nutritional interventions in colorectal cancer, we have to start with the nutritional counseling as the first and most commonly utilized intervention for the management of malnourished patients with cancer and functioning gastrointestinal tract. Second, we go to the nutritional assessment, where we use the nutritional risk screening through 2 criteria. impaired nutritional status, and disease severity. A score between 0 and 3 for each criteria, accordingly. The second tool is the subjective global assessment, which is a tool to assess the nutritional status based on history and physical examination. It's a couple of questions in the history and the physical examination, and accordingly, we get the score. The nutritional requirements and support. According to the nutritional assessment, we indicate a nutritional support. Either oral intake is possible. If so, then a proper diet and oral nutritional supplements, or we assess the stage of the disease and the treatment plan, and accordingly assess the GI function itself. If it's functional, then enteral nutrition. If there is intestinal failure, then parenteral nutrition. Nutritional requirements include the energy needs, the proteins according to the stage, fluids, micronutrients, and probiotics and prebiotics. The energy needs, according to the studies, 2/3 of the cancer patients take less than 25 kilocalories per kilogram body weight per day. This means that they do not cover the minimum needs daily. The normal nutrition status, 25 to 30 kilocalories per kilogram per day. The risk of refeeding syndrome, which is caused by rapid refeeding after a period of undernutrition. It's characterized by hypophosphatemia, electrolyte shifts, and has metabolic and clinical complications. High-risk patients include the chronically undernourished and those with a little intake for greater than 10 days. So at the end, we follow the rule, start low, go slow. The proteins, determining the individual protein, fat, and carbohydrate requirements of patients with colorectal cancer is not straightforward. A patient with cancer should consume more than 1 gram of protein per kilogram of body weight per day, and it's advisable to aim at the supply of 1.5 grams per kilogram per body weight. To increase the protein supply more than that, the renal function test should be monitored. As for fluids, dehydration is one of the main side effects of both the illness itself and the treatment. And this can be caused by a number of factors, such as the sickness itself, diarrhea, secondary infections and/or fevers, bleeding, or simply not ingesting enough fluids during the course of the day. Recommended daily intake is to drink at least 8 to 10 cups of water daily, and of course to limit the caffeine or alcohol-containing beverages. Micronutrients. Among the nutrients most lost by colorectal cancer patients, the following should be mentioned as vitamin D, selenium, zinc, iron, vitamin C, vitamin E, folic acid, and electrolytes. And these are found in the different vegetables and fruits, and also the nuts. Probiotics and prebiotics, they are very important. Probiotics are found in the dairy products, as in milk, cheese, and the prebiotics are found in the vegetables and fruits. They are both important to enhance the growth of the beneficial microbes in the gut, and at the end, for the prevention of cancer itself. The nutritional support, here we're going to talk about if we're going to give the oral nutritional supplements or the enteral or parenteral, according to the case itself and according to the assessment we did at the beginning. The oral nutritional supplements are high in caloric content, high protein, and contains omega-3, and has a good taste. Enteral nutrition, if less than 60% of the requirements for 1 to 2 weeks. So we go for the enteral nutrition. Tube feeding is indicated in case of severe dysphagia and inadequate energy intake. Gastrostomy is also recommended if the tube feeding exceeded more than 6 weeks, as prophylactic gastrostomy placement is also associated with improved quality of life at 6 months. Lastly, the parenteral nutrition. It's recommended in case of complete lack of oral feeding or as a supplement in so-called the mixed nutrition. The bag, it's a mixed formula, which is more than 40% supplement of the daily protein and caloric needs of the patient. It's carried out using central vein, which allows long-term feeding or peripheral access through the peripheral veins, of course. It was proved that parenteral nutrition prolonged survival time in patients with cancer and led to statistically significantly longer survival by 3 months in malnourished patients with disseminated disease. Lastly, our conclusion here, we recommend that, or I'm stating a fact, that nutritional professionals have an important role as a part of the multidisciplinary team in prevention and management of colorectal cancer. Nutritional counseling is the first line of management of malnutrition in colorectal cancer patients. Combining the anti-cancer therapies with proper nutritional support results in improved survival and quality of life. The main aim is to treat the patient and not the disease. Maintaining a good quality of life is the cornerstone of cancer management. Thank you.
Thank you, Dr. Hanan, for this illustrative, informative lecture. غطيتي الموضوع كله زي ما توقعت من سيادتك. شكرا جزيلا.
Thank you so much, doctor.
And again, I have a comment.
Yes.
احنا مش عايزين نطفشهم.